Let's talk about something that happens gradually and often goes unrecognized. You start taking ibuprofen occasionally for neck pain. Then it's daily. Then you need higher doses. Eventually, you're taking maximum doses regularly, maybe adding other medications, and your pain isn't really better, but now you're dependent on medication while the underlying musculoskeletal problem persists untreated. Medication limitations are important to understand clearly. NSAIDs like ibuprofen and naproxen reduce inflammation and pain, that's real. But they don't correct the posture or ergonomics creating the problem. You're managing symptoms without addressing causes. Acetaminophen, Tylenol, has minimal anti-inflammatory effect, so it's even less useful for musculoskeletal pain. Muscle relaxants cause sedation and cognitive impairment without addressing why your muscles are tense in the first place. The problematic usage patterns develop insidiously. Daily medication use for a chronic condition indicates treatment failure, not success. Think about that. If you need medication every day indefinitely, the treatment isn't working, you're just managing symptoms. Escalating doses over time suggest tolerance development. Your body adapts and the same dose becomes less effective. Medication overuse headaches are a real phenomenon where frequent pain medication actually causes headaches, creating a vicious cycle. The risks of long-term NSAID use are significant and underappreciated. Gastrointestinal bleeding risk increases substantially with regular use. Cardiovascular effects. NSAIDs can increase blood pressure and cardiovascular event risk. Kidney damage from chronic use. Acetaminophen has serious liver toxicity risk with regular use above recommended doses. And opioids for chronic musculoskeletal pain carry obvious dependence risks and have minimal evidence of long-term effectiveness. Appropriate medication use is short-term during acute flares while you're implementing ergonomic corrections and other treatments. As an adjunct to physical therapy and ergonomic intervention, not as a substitute. With a plan to taper as the underlying problem resolves. If you can't taper because pain returns, that's feedback that the underlying problem isn't resolved. Non-pharmaceutical pain management deserves more attention. Ice and heat application. These are genuinely helpful for many people and have no systemic risks. Topical analgesics like diclofenac gel provide local pain relief with limited systemic absorption. CBD and cannabis have evolving research, some evidence for pain relief, but legal considerations vary by location and workplace drug testing policies may be an issue. The healthcare system incentive problem is structural and concerning. In a 15-minute appointment, writing a prescription is fast. Providing time-intensive counseling about ergonomics, posture, behavioral changes, that takes much longer than appointment slots allow. Insurance reimbursement strongly favors medication prescription over preventive counseling. So the system pushes toward pharmaceutical management even when behavioral interventions would be more effective. What really concerns me is the opportunity cost. Every day you're managing pain with medication without addressing the cause is a day the underlying problem is progressing. Chronic poor posture creates cumulative damage. The longer it continues, the harder it becomes to reverse. Time spent on medication management is time not spent on ergonomic correction, physical therapy, and lifestyle modification that would actually resolve the problem. The psychological aspect of medication dependency matters too. Taking medication can create a sense that you're addressing the problem when you're actually just masking symptoms. It can reduce motivation to make harder behavioral changes. And it can create learned helplessness, the belief that you need external chemical intervention to function rather than confidence in your ability to resolve the underlying problem. For people currently on the medication treadmill, the path forward involves honest assessment. Is your pain actually better, or have you just adapted to a medicated baseline? Work with your healthcare provider on a tapering plan. You often can't stop suddenly without rebound effects. Simultaneously implement ergonomic and behavioral interventions so you're addressing causes while reducing medication. And recognize that some discomfort during the transition is normal and doesn't necessarily mean you need to resume medication. The goal isn't to avoid all medication. Acute pain sometimes needs pharmaceutical management. The goal is to avoid chronic medication use as a substitute for addressing underlying musculoskeletal problems that have clear, correctable causes.